going to introduce my colleagues, Dr. Tony Goddard, consultant interventional neuroradiologist at my hospital, Leeds Teaching Hospital Trust. Tony, go ahead. You're live.
Okay. Can you see and hear me?
Yes, we can.
Perfect. Okay. Fasten your seatbelts. I'm going to give you a ride through interventional neuro, some career insights, and what I've learned, what qualities that we need. But I'll take a step back. And actually, you know, when you're starting a medical career, you have to think about what's important. I think we'd like to choose something that will offer us a challenge, perhaps progression, career progression over time. It needs to have a decent amount of variety. I think interaction with people and different specialties is important. Respect from colleagues, work-life balance, and a supportive work environment. Whatever we do, I think that's important. And I will say it's not just about the procedures, which are very enjoyable, but I think interventional neuro gives us quite a broad range of things. We treat aneurysms and stroke. We can get involved in atheroma stenting, vascular malformations, and preoperative embolization of tumors, but we can do some functional testing. We all are also adept at diagnostic imaging. I think the MR of the brain is still very interesting, but we do clinics. We get involved in research, we get involved in teaching and training, and we also get involved in plenty of meetings. We're also at the heart of lots of different specialties. We interact particularly strongly with neurosurgeons, neurologists, vascular surgeons, vascular radiologists, and radiologists. We're involved in the clinical side, A&E, ENT, pediatrics, orthopedics, academia. And actually quite an important comment at the bottom is that the international INR community is actually a pretty supportive bunch. If you have a difficult case, you can use WhatsApp and you can send a case to Professor Benny Chapeau in Essen, and you may get a quick response to help you. And we even have this live, and we have live proctoring as well. So international INR community is quite important. If you like technology, I think we're all here because we like that. We get involved in angiography, ultrasound, MR, CT. You can do functional advanced MR. Artificial intelligence is making inroads into interventional radiology and radiology in general, and of course fluoroscopy. Now, we haven't got here from nowhere. This is Orion with the blind Orion with the dwarf on top, helping Orion search for the dawn. And on the right is the stained glass of the church at Chartres, Cathedral at Chartres. And on the right, on the left, we have the Old Testament prophets on whose shoulders are standing the New Testament script writers, seeing further and deeper. So we have built up INR as a relatively young specialty on the shoulders of quite amazing people. Isaac Newton appropriated.
Sorry, Dr. Goddard, just to interrupt. Sorry, we're just not seeing your slides at the moment. If you'd be able to just share screen with the little monitor button. Oh,
are you not seeing them at all?
No.
Oh.
It's been very interesting so far, and I think it will just complement
now
this.
Then, okay. Sorry, I was getting into my stride. In terms of sharing,
so do you see the video, mic, and monitor button as well as the settings button? Within Hopin?
No, I'm in the wrong bit, aren't I? So in the YiiRS meeting itself.
Yeah, so where you see your own video, you should also see a few buttons at the bottom of the page.
Right, hold on a sec. Right, okay, sorry. Where does it say share? Sorry.
So there should be a video recording, a mic button, and a monitor.
Got a line through it. How about this?
Yeah, if you click the line through it, and then you can click the screen that you want to share, which is probably...
Can you see this now?
No, not yet.
Okay. Oh, right. Sorry. I think a dialog box came up.
Yes.
Are you seeing it now?
Yes, we see it nanos gigantum humerus incidens.
Thank you.
So yes.
Okay, no worries. I think there was some extra security on my Mac. Right. I won't go back because you've heard everything. So anyway, Isaac Newton appropriated these classical references in his very famous quote, "And standing on the shoulder of giants." I won't dwell too much because we've lost a little bit of time. But radiology in general is quite a young specialty. X-rays were discovered in 1895 by Röntgen, who X-rayed his wife's hand and diagnosed some arthritis. In that, he got the Nobel Prize of Physics in 1901. Antonio Egas Moniz, a Portuguese neurologist, was the first person to inject radiopaque contrast into arteries and X-ray them. And he used strontium and lithium bromide. One patient died. He also invented lobotomy. So slightly controversial figure, but he helped get us where we are. This is also Seldinger. We've seen the Seldinger technique already. This is a Swedish radiologist. He looks like a Swedish newsreader about to break some bad news about COVID, but he was a radiologist. And actually, he came across things by accident. The quote at the bottom is quite interesting. He had a needle, a wire, and a catheter, and in a split second, he realized what sequence he should use: the needle in wire and needle off, and then catheter over the wire. And of course, we're still using that technique today. Charles Dotto was an American radiologist who performed the first transluminal percutaneous angioplasty. He was an interventional cardiologist and worked with Judkins, and good design lasts, and the Judkins catheter is still in use today. And in neuroradiology, we actually use Judkins catheters for spinal angiography. It's a very useful tool. We then came to a Russian neurosurgeon who used latex detachable balloons to actually put these into large intracranial aneurysms. And he published some positive results in 1974. And Gerard de Brun brought this technique into the West in the early 70s. But I would say that the real father of neurointervention currently is Guido Guglielmi. People might have heard of the term GDC coil, and Guglielmi is the G in GDC. He's an Italian neurosurgeon who was influenced by a previous neurosurgeon called Mullen, and also his own father suffered a subarachnoid hemorrhage. And alongside Ivan Sepetka, who arguably is the real genius behind it, who doesn't really get the recognition, he was an engineer from a company called Target Therapeutics, now owned by Stryker. And Fernando Buñuel invented a coil that could be deployed and redeployed and then eventually detached by way of electricity. And this was an excellent device. At the same time, there was a clinical problem with aneurysmal subarachnoid hemorrhage insofar as surgery was the mainstay of treatment. The problem with aneurysmal subarachnoid hemorrhage is that aneurysms had a very high early rebleed rate in the first few days, but that is when the surgical morbidity and mortality is very high. So there was a tendency to wait for patients for the natural course of rebleeding to take its course and operate quite late in these patients and get good outcomes. So quite a few patients were lost. So there really was a need for development of a non-surgical treatment. Now, this is the cover of a Journal of Neurosurgery in which the two seminal papers of aneurysm or the development of aneurysm coiling were published, and these are actually below a paper on prophylactic antibiotics. And it's not uncommon for a new development. The impact of this is not to be realized at the time. The three gentlemen are below, and this is a design on the top left. I'm not sure if you can see my pointer. Hopefully you can, of the coil design. And actually, this is 30 years old now, but again, good design lasts, and there's been a few modifications, but essentially it's the same. We have a platinum coil with a shaped memory attached to a stainless steel wire, and the method of detachment is by placing electrical current through the wire and leaving the coil behind. I'll show you some pictures in a minute. And the first treatment was done on 15 patients, all awake with aneurysms, which are very difficult to treat otherwise. Very good results, and this led to an FDA multi-center study. But actually, the UK pretty much overtook it, and the next sort of quantum leap, a bit like stroke, which we'll come to, is actually providing very good quality evidence. And I would say, whatever you do, if you want to develop a new study, providing good quality clinical evidence, preferably in a randomized controlled trial, is often really the way to change practice. So this is what happened for us, International Subarachnoid Aneurysm Trial. It randomized clipping versus coiling in an eligible population in patients who had acute subarachnoid hemorrhage. And the facts came out, I can't believe it's nearly 18 years ago now, 3rd of May 2002, where the trial was actually terminated because the end of the trial was actually sort of reached in terms of outcomes. So there was a relative reduction in adverse outcomes in patients who were coiled versus clipped to 22.6%. an absolute risk reduction of 6.9%. Now, that doesn't sound a huge amount, but it meant that in every 100 patients, 7 of those 100 patients will be independent at 1 year if they were coiled rather than clipped. Now, this had a huge impact. Pretty much the same day we had a chat with our neurosurgeons, this led to an immediate change in policy to coiling. The bottom thing's meant to be a question mark. And also, if you don't need to open the head, then why do it? Air on the brain, never the same, is one adage. So here's a case where actually in any era, this would be quite difficult. This is a very large symptomatic but not ruptured basilar aneurysm pressing on the brainstem. It's a very large aneurysm. The natural history of this lesion is extremely bad. If this does not rupture, it will cause progressive brainstem compression. Quite difficult access. We can see there's vessels coming off the base of the aneurysm. But with a variety of devices, which I will show you, a combination of using a balloon to protect the vessel, putting multiple coils in here. You've got large coils to put in, and then put what's called a barrel stent. This has actually been superseded. It's a stent that sits across the base of the aneurysm with a fat belly, like a snake eating a wallaby. And that sits across the base of the aneurysm. That allows me to put more coils at the base of the aneurysm and get an excellent result. There was a question about how long do some cases take. This is my longest neurointerventional case, and it took me about 7 hours. But actually, this has been a very durable result for this patient, and it looks very good. So the next thing, and the big advance now, is actually treating stroke. And this has only been a going concern, certainly in the last 5 or 6 years, as this has really taken off. Now, and this is where we can really make a difference to patients. That's meant to say year rather than ear. So the clinical burden of stroke is enormous. 150,000 occur in the UK each year. It accounts for 53,000 deaths. Third biggest killer for coronary artery disease and cancer, leading cause of disability, and a third of a million live with disability in the UK, and is not just a disease of old age. A quarter of strokes will occur in patients under 65 and 20,000 in younger than 45. And we do treat pediatric strokes. It's also very expensive, with an average patient cost of 15 to 30,000. And there's indirect costs, which is loss of earnings and loss of taxation to the economy. So it has a huge impact. It's been a real Cinderella sort of area for neurointervention. And you can say, well, this is no big surprise in some studies. This is only 2007. If you open the vessel early with stroke, and you do it quite quickly, patients do quite well. But it's taken 40, 45 years of medical research to actually state what seems to be pretty self-evident. But we also know that with the drugs that are available for stroke, such as TPA, if you have a large vessel occlusion, that is a carotid or proximal middle cerebral artery, the chance of opening that vessel is actually quite low, only 1 in 5. And if you don't open the vessel, the patient will not do very well. The whole ethos of treating stroke very quickly, and the model that we have, is if you have an embolus blocking an artery and it usually lodges at a bifurcation, there is a central core of tissue that will infarct immediately and will not be salvageable. But there is a penumbra around there where tissue is not getting enough blood to perform normally, and that contributes to the clinical presentation. But if you restore blood supply, that tissue will recover. This is hibernating to the penumbra. But what happens over time is that this core gradually increases in size over 4, 5, 6 hours. So by 6 hours, the core is the same size as the penumbra, and you've lost the opportunity to save the patient. So time is brain. And a neurologist with plenty of time on his hand has actually done this calculation. This gets quoted quite a lot. And for every minute of occlusion infarction, that you lose 2 million neurons and 14 billion synapses and 12 kilometers of nerve fibers. Again, when we're managing stroke, it's like Mike Brailsford's incremental gains in sort of cycling. We need to save a minute fairly quickly. And I'll show an example of a patient who sort of presented to us and the kind of things that we get. 69-year-old, NHS of 17. This is a clinical stroke severity score, which is actually very high, particularly for a right-sided stroke. It's a smoker, but previously fit and well. The CT scan now is a gateway investigation. We don't use fancy MR perfusion techniques in the acute management of stroke. And what we can see as a marker for large vessel occlusion and the likely poor clinical outcome is what's called the hyperdense middle cerebral artery, and we can pick this up immediately. But the clinicians being in the stroke team around, the back nurses, brain attack team nurses, will also have a feel that the patient is actually in a bad way from the stroke. This is a CT angiogram reconstructed in the coronal plane. We can see the carotid here, and we see the vessel is missing here where there is some thrombus. There is some backfilling, but this patient is likely not going to do well. We also do a CT angiogram of the neck vessels. We found that 1 in 5 patients almost that we treat have a carotid stenosis. This is the jugular vein. The patient looks like there's some thrombus here in the carotid bifurcation. So in these patients, we kind of need to do 2 procedures fairly quickly. The first thing we need to do is to get past that carotid stenosis. And there are 2 schools of thought here. Some people don't necessarily put stents in. We have to angioplasty it and then we place a stent, and then we do a post dilatation, so there's a carotid stent in place. We then get the guiding catheter through the stent higher up and do the second part of the procedure, which is the thrombectomy itself. Some people advocate being less aggressive and just angioplasting and not placing a stent, because you have to put the patient on antiplatelets. Once we're through the stent, we have a look at this, and it looks terrible. There is really no flow beyond here. This actually looks worse than the CT angiogram, which is not uncommon, but we have thrombus here blocking the outflow. So the next part of the procedure is to take a thrombectomy device, which is like a stent, which is attached to a delivery wire, and that engages with the clot, and we pull the clot through, and we get an image like this, which is extremely satisfying. We've now got reperfusion, and this is the kind of thing that we see. So we go fishing in the brain. And this is a serendipitous discovery. This is like an aneurysm device, and it was discovered by the team in Stuttgart that it also managed to retrieve clot. So this is clot retained within the device. And particularly satisfying are 2 things. The CT at 24 hours is very good, showing only minor ischemic change, but particularly the patient NHS went to 0, which means they have fully recovered. And then self-discharge 48 hours post-stroke onset. His natural history would either be death or permanent disability and likely long-term hospitalization. If you compile the evidence together, and you can stratify it and compare it to other interventions that we accept as part of general medical practice and don't really question the efficacy, stroke performs extremely well. We give lipid-lowering agents. For people with hypercholesterolemia, you have to give 98 to prevent one heart attack. Aspirin for prevention of 1 cerebrovascular event, 50. We give warfarin or an anticoagulant and atrial fibrillation to prevent stroke. That's 18. We see all this. Vaccination, 1 case of flu, 30. I don't know what it is for COVID. But here comes thrombectomy down at the bottom of the list. We only need to treat between 2.8 and 4 people to benefit one patient, and that's in line with antibiotics and chronic airway disease exacerbation and defibrillation for cardiac arrest. It's a very, very, very powerful intervention. But given that this is a day where we're showing some cases, and it's a day of collaboration between interventional radiology, neurology, cardiology, and apologies to Satner if she was going to present this earlier, but this is an amazing case where we all got involved with a few years ago to show that actually, particularly in Leeds, we've got vascular IR and neuro IR next to each other, and I think that's quite important because sometimes we certainly need vascular IR help from time to time, and they need our help from time to time. This is a lady of 55 who had a road traffic accident before. She wasn't seriously ill. She was resting up in bed and attended with left groin pain and swelling. And this is a CT scan. And what we're seeing here, I don't do much body CT, but this is a swollen iliofemoral clot expanding the vein here. So because she's been bedbound, she's developed extensive DVT. We then got her off the scanner, and then she became acutely short of breath. And she had some ECG changes. We got her back on the scanner and then scanned her chest with some X-ray dye, and we found that there were multiple filling defects in the pulmonary arteries in this patient. So she was getting multiple pulmonary emboli. So this was an unstable clot. She then got off the CT, all prepared for some thrombolysis, and then she became acutely agitated and confused. So we got her back on the CT, and lo and behold, we see that sign again. We've got this hyperdense right middle cerebral artery, so the clot is now moving northwards. Now you can think about what might be going on from a pathological basis. We did a CT angiogram where we inject X-ray dye that highlights the occlusion here on the right, but also we see the right carotid in the neck and the skull base is normal, but the on the left it's actually completely occluded. So she's actually occluded both carotids. So then we have to think on our feet pretty quickly, and we do things in reverse order. You've got less time with the brain. So we do an angiogram with the patient under anesthetic very quickly because she's very confused and losing her airway. This is the right middle cerebral artery before treatment. It's completely gone. We do one pass with a thrombectomy device and it's now opened. We then take a catheter from the same femoral puncture into the left. This is the trajectory of the left internal carotid artery, which of course is missing. We've seen that. We do one pull or aspiration of the clot in the left common carotid artery, and it's now open. Now, because our angio rooms are quite sophisticated, we didn't realize this. It has a cardiology setting on our Neuroadioogy suite, which we only found out today. So the cardiologist came down, but because she had some right heart strain, we managed to do a coronary angiogram on that patient at the same sitting, which was normal. The cardiologist then put a PFO closure device in because the pathogenesis of all of this is that the clot's expanded from the leg up into the chest and through the right heart to the left and intracranial circulation. They put a PFO closure device all in the Neuroadioogy suite, and then Sapner to prevent further catastrophic embolism, put an IVC filter in the patient, all at the same sitting. The irony of this case is that it was performed on the day of the junior doctor strike, I think now 4 years ago. We had 11 consultants working seamlessly together, and the patient was actually discharged fully ambulant NHS of 1. So you know, we do need to help each other out from time to time. But in terms of general career and what interventionists do, well, we can broadly categorize it into things that we close up that shouldn't be there, such as aneurysms causing brain hemorrhage, arteriovenous malformations, where we can do a targeted treatment to treat aneurysms which are ruptured in these lesions, or flow aneurysms. We can rarely cure AVMs, dual fistulas, and we can help the surgeons out. And we can pre-op embolize spinal tumors, particularly renal carcinoma metastases, intracranial tumors such as meningiomas. We open things up. Stroke, we've seen. We do venous thrombectomy sometimes as well. We do intracranial, extracranial stenting, and there is a condition with intracranial hypertension where we actually put stents into the venous sinuses as well in carefully selected patients. If you want to, you can get involved in vertebroplasty, but that's orthopedic surgeons also like that. Epidural blood plaques for intracranial hypertension or hypotension. We also do plenty of diagnostic angiograms. This is a water test where we inject either a barbiturate, and last week I injected propofol into a carotid artery to anesthetize half of the brain in an awake patient to do psychological testing on the other side to work out what the effect of removing the temporal lobe would be. It sounds crazy, it felt crazy, but it helped the patient. And balloon tests. And if you like, this is an old picture now, which I've nicked from an old slide. We all like expensive, sexy kit. This is a biplane angiogram. We can look in 2 planes simultaneously. We've also got a license where we can watch a bit of TV in some downtime whilst we're doing procedures. But there's lots and lots of different devices. A new set of devices called flow diverters are very good, but these are very high mesh density stents which are placed in the parent artery, which are very good for occluding aneurysms. We've got funky devices we can put inside aneurysms. This is a new contour device which has only got CE marking last year, and it's I think perhaps it's the closest thing to an endovascular clip that we've had in neuroradiology. And the idea is this is a high density mesh stent you put at the base of the aneurysm. This acts like a disc, and the radial force of the device holds it in position. We've also got other devices which this contour device might supersede. It performs the same function. It's like a stent with a flared end that sits at the base of an aneurysm. These are all required partly because coiling is not necessarily durable for some large aneurysms, and we do need good devices for dealing with the neck of aneurysms. So there are still plenty of advances in neuroradiology. But there's also advances in other ways. Okay, this is just a sum of different kind of things. It's about the technique and technology, but there's other things involved. There's lots of clinical trials going on about treating to infarct core, do this to your benefit. treating more distal occlusions in arteries. So there's plenty of ongoing clinical trials to answer some of these questions. We've also got new service developments. For example, in the chronic subdural hematomas, the dura becomes vascularized, and now we can embolize the middle meningeal artery. We can actually embolize and devascularize the dura. That reduces the risk of things recurring. So there are new indications. There are also technological advances. Smaller flow diverters for these more distal aneurysms, smaller thrombectomy devices for more distal vessel occlusions. So there are technical things. We have true translational research. There's plenty of work on biological materials that you can put inside an artery that will occlude an aneurysm, but that will then dissolve and obviate the need for ongoing antiplatelet medication. So there's some plenty of stuff that will involve collaboration with the university. We've also got some software developments, artificial intelligence for better selection of stroke patients. I'll just show this. This is a perfusion map of a patient with a stroke, and this is a visual depiction of the graphic that I showed before, showing the difference between the infarct penumbra, which is in green, and the infarct core is in purple, and if there is a discrepancy between the two. If the infarct core purple is very small, then we might well do this stroke treatment. There's an app on the phone. We can get notification on our phone now about these, which may be a good or bad thing depending if you're on holiday or not. But we're also using computational flow dynamics for better prediction of natural history of aneurysms. That's a real weakness. Is when we find an aneurysm in an asymptomatic patient, how do we know how it's going to behave? Should we treat it? Should we not treat it? Should we observe it? And we can also predict some response to treatment. So this is some work we've done with Jai Patel and the vascular guides and the people in the university using CT and MI angiography. This is actually a visceral aneurysm that we've treated. Again, collaboration's key. It's part of the excitement and fulfillment of the job. And this predicts how many coils we're going to need in the aneurysm to be able to occlude it. It predicts how the stent might behave, and you can put different coils in and different size of coils, so you can actually have a virtual sort of treatment before you start. And actually published just Thursday in the American Journal of Neuroradiology is some crazy stuff about robotic intervention. I think we might have touched on this. And you, rather than having some hands-on, you have somebody behind the screen, and they're actually directing with a joystick. And this is where maybe gamers will come in the future generation. Will be very good at this kind of intervention. We've got a series of rollers, magnetically guided guide wires and catheters to catheterize the vessels. I've seen the presentation of this, and I can tell you it's slower than I can do it, but never mind. But here's where we could. Where it could go. You could have a telerobotic stroke network, and you can actually manage several stroke interventions at the same time. These are people thinking definitely outside the box as to where we could be in a few years' time. So in terms of INR as a career, and hopefully I'll have caught up sometime, and this will be discussed later. You may have a previous undergraduate degree in medical school, of course. You do your foundation years. You may do some specialty training. We do radiology training. Years 1 to 3 is in general radiology, and then you have to get your FRCR examination. In interventional neuro, there are another 3 years. So we have an extra 6 years subspecialty training. Year 4 is diagnostic. Year 5 is a sort of hybrid diagnostic interventional year. And year 6, you'll be full on doing intervention and leading cases. And then you have your post-CT fellowship. I personally think it's probably beneficial if you move to another center. I think it's quite difficult nowadays doing that. I certainly benefited from it, but it's quite a demanding specialty, particularly when things go wrong. Complications are usually life-ending or life-changing because it's a neurological condition, and when you see patients in clinic, they may well have been through all sorts of other things, cancer treatments and other. I've even seen transplant patients get over it, but when it's the brain, it's a different level of anxiety. So for neuro, you need the following skills, such as patience and tenacity. I think this is for IRSO. You certainly need diplomacy. You need to develop a high level of technical skill. And I'll say an important point. I don't think you're born with technical skills or innate ability. These can be taught with practice. I'm a left-handed interventionist. I've taught myself to use right-handed. You can teach yourself technical skills in a supportive environment. You do need some psychological resilience. And again, I think this is something that you need support for and develops. You need to be empathize with patients. You need to be able to delegate and work with a team, but also it's your responsibility ultimately, often if things don't go to plan. you need to be a conductor and a facilitator. If you're managing a stroke patient, you have to be around to coordinate and conduct people. And you've got to be a leader in the room. Keep a cool head. So to finish off, this is a very quick talk. What do you want for yourself? I couldn't be a GP working in some practice, listening to people, just complaining all day. I say to people, if you see me in work, you've got to be seriously ill. I think it works quite well. I'm not sure if vascular IR or surgery is for you. I think it's a bit messy. You've got blunt tools for some of the things that you need. Well, with INR, you can have this. You can have a dynamic team. Let's say we all save lives. I'm not going to denigrate this, but I think I will say that stroke intervention is the best thing I've ever done in medicine. And a question was asked earlier about what is the most rewarding thing you can do in Neuro-IR, and I wish I had a video of it. The most rewarding thing you can do is have a patient transferred by paramedics who's not moving their right side and not able to talk. You identify a left-sided vessel occlusion. You can take the clot out in less than half an hour, and the patient starts moving and talking. We did have a patient like this who was on the phone back in the ambulance going back to the praying hospital, talking to his family, saying, turn around, it's all done, I'm doing very well. So you have a dynamic team. Yes, you've had a stroke. We have the backbone, we have the back team, the brain attack nurses will coordinate things. We've got Spock, the stroke physician on call, who will help things. We've got the neuroradiologist, and we're going to go ahead. Yes, we're going to treat the stroke, and Thunderbirds will go. The team is in action. And there is quite a bit of excitement when we get a stroke. And I think I'd like to think that the team we work with, the vascular radiographers, the vascular nurses and clinicians and people see this as and the anaesthetists too, see this as a very rewarding enterprise. You can also have some fame. This is a little while ago. My colleague, Dr. Patanka, on live TV with our fellow Hannah Stockley doing a live thrombectomy. It was filmed live and broadcast, and then of course Dr. Papala in there offering her thoughts. But you can also have this as a lifestyle. It's quite important. These are various meetings. Okay, I will admit that one of these is a holiday photo, but can you tell which one? Dubai, this is the RSNA in Chicago, the largest radiology meeting in the world, 100,000 people. San Francisco, Monaco, Singapore, Naples. We get to go to some quite exciting places. You can get treated like royalty. This is last Christmas when we were allowed to do these things, and hopefully we'll get back there again. We get treated by royalty when we're out there. It's a very rewarding. But finally, I would like to say that neuroradiology, interventional neuroradiology, is sexy, and we know it. Sorry for the picture, and I haven't made up these banners just yet. They will be on sale later. But coming back to the first slide, I'm making a sort of fairly serious point, which is applicable to all of us. What we want from a career, I think, is to be challenged and to use our intellectual gifts for the benefit of people, but also to be stimulated. I think career change and career progression is good. Having variety and interaction with different specialties is really quite exciting. You'd like to be respected and appreciated for your job, work-life balance, supportive environment. I've added fair compensation. I still think as doctors we're quite well paid, and we've been lucky during all of this COVID to have a job and sort of career stability. But this is what everybody wants. It's not just for us. It's not just about us. This is for all the nurses that we work with as well also want this. So what we need from anybody who's going into a career in intervention is that we need from you to respect all the colleagues that you work with, and of course the patients. We do need some hard work. We need tolerance when things aren't going well. You need to be fair. You need to be communicate and collaborate with people. And I think, if you do that, whatever you do, I think you'll be a success. So I'll 5 minutes late. I'll thank you for your attention, and good luck with whatever you do. I'll take any questions.
Thank you so much, Dr. Goddard, for that. That was very inspiring. We've got a quick question here. How do you feel about training interventional cardiologists for out-of-hours stroke interventions? Will it be an idea going forward to improve access to 24/7 stroke intervention?
Yeah, that's a very good question. Very insightful, because the cardiologists, of course, have the surface infrastructure to be able to do it. our calculations, and there's good quality data on UK maps for stroke, is that we don't actually need them. And the brain is not the heart, and the heart is not the brain, and the different specialties. Yes, you can treat a stroke in 10 minutes, but it can be quite a long time, and we need people who can deal with complications and difficulties. We also need people who can interpret the imaging and make clinical decisions. So I know there's some interventional cardiologists who are interested. At the moment, I think the people who are best placed to help us are interventional radiologists. In other countries and other centres, it's a very different sort of setup. But I think in the UK at the moment, much as there is interest and we think it's a very useful thing, we don't think we need interventional cardiologists to help us.
That's great. And what do you think are the major barriers to UK-wide 24/7 service provision for stroke thrombectomy?
Okay, excellent question. People, personnel. We've got a standard operating procedure that we've agreed with Hull and Sheffield. We've got buy-in from Yorkshire Ambulance to move patients around. We have got good data on timelines. For example, moving patients from Chesterfield to Leeds and bypassing hospital doesn't add much time. The problem we have is having enough radiographers and nurses and keeping those people. So for Leeds, for example, we have a setup to link with Sheffield to help us, but we do not have enough nurses and radiographers to have a separate on-call rota. So we are on a recruitment drive. Money, I don't think even money from the procedural part issue is quite well remunerated in terms of the HRG code. So we make money. And there is good evidence. So it's people that we need. I think that's the main thing.
That's great. And I'll just take this one last question, which is: have you had a chance to use the CorePath GRX system personally? If so, is it difficult to control? This is the virtual thing.
It's a question coming from Keenan.
It's on this.
You have to explain what it is, and that gives you the answer. I think I've used simulators, and that's going to come in. But in terms of it's the robotic thing. No, I'm not a big fan of that. I don't think that's one of the reasons why we like interventions, getting hands-on. So no.
Great.
I don't think it's not for me.
Thank you very much for that again, Dr. Goddard.
Right, I need to unshare, don't I?
Thank you, Tony, for coming. It was brilliant.
All right, no worries.
Thank you.